Good evening once again, consultants, colleagues. Um, like we all agreed, the weekend will be for the guideline presentations. And starting today, we have Dr. Florence Akumia to start the presentation with us on the ESC guidelines on acute and chronic heart failure, the 2021 and the 2023 updates. She will do the presentation, and when she's done, let's kindly note our questions and contributions so that when she finishes the presentation, we can now come in. We are not to exceed more 2 hours today. That was the agreement, 6 to 8 p.m. Thank you. So Florence, kindly start.
Okay, thank you, Eugene. So we'll go straight into the presentation. I'm Dr. Florence Akomia. I'm in the Kolibu Teaching Hospital now. So this is the outline we are going to use. The slides may appear dense, but we'll go through it bit by bit. So essentially, heart failure is a clinical syndrome, and we know that it consists of cardinal symptoms, which may be accompanied by signs, and then it may be due to structural or functional abnormality of the heart, resulting in elevated intracardiac pressures and/or inadequate cardiac output, either at rest and/or during exercise. So this is how the ESC came up with the universal definition of heart failure, which I'm sure we are all familiar with. And this, the symptoms and/or signs which are caused by these structural and/or functional cardiac abnormalities are to be corroborated by biochemical parameters like elevated natriuretic peptide levels and/or objective evidence of pulmonary or systemic congestion. So that leads us to how we make the diagnosis of heart failure. And by virtue of that, heart failure was classified into 3 main groups. Heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, previously known as mid-range ejection fraction, and heart failure with preserved ejection fraction. So the first criteria is by presence of signs and symptoms. The second criteria is by the LV systolic function. So if it is less than or equal to 40, then it's reduced. 41 to 49 is mildly reduced, and more than or equal to 50 is preserved. And then the third criteria is when you have objective evidence of the cardiac structural and/or functional abnormalities. So that's usually required in the case of heart failure with preserved ejection fraction. Okay, so before we go into the guidelines and its recommendations, we're going to first look at the classes of recommendations by the European Society of Cardiology. So they have them in levels, the level of evidence. So we have level A, B, and C. Where level A is data derived from multiple randomized clinical trials or meta-analysis. And then level B is data derived from single randomized clinical trial or large non-randomized studies. And then level C is a consensus opinion. Consensus of opinion of experts and/or most studies, retrospective studies and registries. So these are the classes of recommendation based on the level of evidence. And sorry, this one. Okay, so the classes of recommendation, we have class 1, class 2, which is sub-classified into class 2A and B, and class 3. So for class 1, we have evidence and/or general agreement that a given treatment or procedure is beneficial, useful, or effective. So you'd usually find a class 1 evidence colored green, meaning it is recommended or indicated. In class 2, there may be conflicting evidence and/or divergence of opinion, about the usefulness or efficacy of the given treatment or procedure. So that is subclassified into two, where the 2A is usually classified by yellow, which means it should be considered. And then 2B is orange, which says may be considered. And class 3 is evidence or general agreement in the given treatment or procedure is not useful or effective, and in some cases may be harmful, so it's not recommended. So these are the various classes we are going to be using in our discussion moving forward. So for the 2021 guidelines, so the thing with guidelines is that every time more studies are done and then there's more evidence to inform treatment, there are revisions to the guidelines. So what was new in the 2021 guidelines was the change of the term heart failure or with mid-range ejection fraction to heart failure with mildly reduced ejection fraction. And also a new simplified treatment algorithm for heart failure with reduced ejection fraction, and the treatment algorithm for heart failure with reduced ejection fraction according to the phenotypes, which was added to the management algorithm. And then also the modified classification for acute heart failure and updated treatments for most non-cardiovascular comorbidities, including diabetes, hyperkalemia, chronic kidney disease, iron deficiency, and cancer. And then addition of key quality indicators. So this was what was new for the 2021 guidelines. So we're going to go briefly into what was new before we come into an in-depth review of the 2021 guidelines as a whole. So for the recommendations for the diagnosis of heart failure, it was a class 2A recommendation that right heart catheterization should be considered in patients where heart failure is thought to be due to constrictive pericarditis, restrictive cardiomyopathy, congenital heart disease, and high output states. And it was a class 2B recommendation that right heart catheterization may be considered in selected patients with heart failure with preserved ejection fraction to confirm diagnosis. And then under the treatment of chronic heart failure, especially for heart failure with reduced ejection fraction, there was a class 1 recommendation for the use of SGLT2 inhibitors, dapagliflozin and empagliflozin for patients with heart failure with reduced ejection fraction due to reduce the risk of heart failure, hospitalization, and death. And then there was a class 2B recommendation to use vericiguat in patients with NYHA class 2 to 4 who had worsening heart failure despite treatment with ACE inhibitor or ANI and beta blocker and MRA agonist, mineralocorticoid receptor antagonist, to reduce the risk of CV mortality and heart failure hospitalization. Still on the recommendation for treatment for heart failure with mildly reduced ejection fraction, class 2B recommendations were made for the following: that an ACE may be used or may be considered for patients with HFmrEF to reduce the risk of hospitalization, and ARBs may also be considered for the same effect. And then beta blockers may be considered in patients with HFmrEF to reduce the risk of hospitalizations and death. Same for the MREs. So ACE inhibitors, ARBs, and beta blockers and MREs were to be considered for treatment to reduce the risk of hospitalization and death. Also, there was recommendation made for the use of ANIs in the case of heart failure with mildly reduced ejection fraction to reduce the risk of hospitalization and death. For heart failure with preserved ejection fraction, there was a class 1 recommendation screening and treatment of etiology and cardiovascular and non-cardiovascular comorbidities were made for patients who had heart failure with preserved ejection fraction. So the indication was to treat the underlying etiology and then the cardiovascular and non-cardiovascular comorbidities that were associated with the heart failure with preserved ejection fraction. And that was a class 1 recommendation. So we have looked at the diagnosis and the role of right heart catheterization, and we have looked at the treatment of chronic heart failure in the case of heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. And we are now looking at what was new pertaining to the prevention and monitoring of heart failure. So a class 1 recommendation was made for self-management strategies, and these were recommended to reduce the risk of heart failure, hospitalization, and mortality. Class 1 recommendation was also made for either home-based and or clinic-based programs that improve outcomes and are recommended to reduce the risk of heart failure, hospitalization, and mortality. Class 2A recommendations were made for vaccinations for influenza and pneumococcal vaccines as a way to prevent heart failure hospitalizations. And also, a supervised exercise-based cardiac rehabilitation program should be considered in patients with more severe disease, frailty, or with comorbidities. Then a class 2B recommendation was made pertaining to non-invasive HTM that it may be considered for patients with heart failure in order to reduce the risk of recurrent cardiovascular or heart failure, hospitalization, and cardiovascular death. For the recommendations for management with patients with advanced heart failure, class 1 recommendation was made for patients being considered for long-term
Hello, Florence. Hello? Can I be heard?
Sorry, the call interrupted me.
Oh,
So
yes.
a recommendation was made to be considered for long-term mechanical circulatory support in the case where they must have good compliance and appropriate capacity for device handling and psychosocial support. And then heart transplantation is recommended for patients with advanced heart failure, refractory to medical or device therapy, and who do not have absolute contraindications. So class 1 recommendation was made for long-term mechanical circulatory support, as well as heart transplantation in patients who did not respond to medical and device therapy and didn't have contraindications for heart transplantation. And a class 2B recommendation was made for continuous inotropes and or vasopressors that they may be considered in patients with low cardiac outputs and evidence of organ hypoperfusion as a bridge to mechanical circulatory support or heart transplantation. So recommendations were also made pertaining to management of patients after heart failure hospitalization. And class 1 recommendations were made for the following. It is recommended that patients hospitalized with heart failure be carefully evaluated to exclude persistent signs of congestion before discharge and to optimize oral treatment. It is also recommended that evidence-based oral medical treatments be administered before discharge. And then an early follow-up visit is recommended at 1 to 2 weeks after discharge to assess signs of congestion, drug tolerance, and or titrate evidence-based therapy. The recommendations were also made for the management of patients with heart failure and atrial fibrillation. Class 2A recommendation was made for long-term treatment with oral anticoagulation, and that this should be considered for stroke patients in atrial fibrillation. For stroke prevention in atrial fibrillation with CHAVA score of 1 in men or 2 in women. So we are dealing with the comorbidities now, heart failure with comorbidities now. So for the heart failure with chronic coronary syndrome, recommendations that were made for the management include the following. There were class 2A recommendation that coronary artery bypass graft should be considered as the first choice revascularization strategy in patients suitable for surgery, especially if they had diabetes and for those with multivessel disease. And then also left ventricular assist device candidates needing coronary revascularization CABG should be avoided in those patients if possible. Thus, Class 2B recommendation that coronary revascularization may be considered to improve outcomes in patients with heart failure with reduced ejection fraction, chronic coronary syndrome, and coronary anatomy suitable for revascularization after careful evaluation of the individual risk to benefit ratio, including coronary anatomy, comorbidities, life expectancy, and patients' perspectives. And then PCI may be considered as an alternative to coronary artery bypass graft based on the heart team evaluation, considering coronary anatomy, comorbidities, and surgical risk. So stronger recommendation was made for coronary artery bypass grafts as opposed to PCI, but PCI was an alternative if the patient was not suitable for coronary artery bypass graft. For heart failure with valvular heart disease, Class 1A recommendation was made for aortic valve intervention using TAVI or SAVR in patients with heart failure and severe high gradient aortic stenosis to reduce mortality and improve symptoms. There was also Class 1 recommendation that the choice between TAVI and SAVR be made by the heart team according to individual patients' preference, features including age, surgical risk, clinical, anatomical, and procedural aspects, weighing the risk and benefits for each approach. So either options were feasible, and the decision was to be made by the heart team on an individual basis. Then percutaneous edge-to-edge mitral valve repair should be considered in carefully selected patients with secondary mitral regurgitation, not suitable for surgery, and not needing coronary revascularization, who are symptomatic despite optimal medical therapy, and who fulfill criteria to achieve a reduction in heart failure hospitalizations. So in the case of mitral valve regurgitation, secondary mitral valve regurgitation, where the patients were not eligible for surgery and did not need coronary revascularization, percutaneous edge-to-edge mitral valve repair was recommended, and the evidence was Class 2A. Then for percutaneous edge-to-edge mitral valve repair may also be considered to improve symptoms in carefully selected patients with secondary mitral regurgitation, not eligible for surgery and not needing coronary revascularization, who are highly symptomatic despite optimal medical therapy and who do not fulfill criteria for reducing who do not fulfill criteria for reducing HF hospitalization. So Class 2, there's previous one was a Class 2A recommendation for those who fulfill criteria to achieve reduction in heart failure hospitalization. But in this one, it is for those, a Class 2B recommendation for those who are highly symptomatic, however, do not fulfill criteria for reducing heart failure hospitalization. So that the difference should be noted. Then we had heart failure with diabetes. So there's a Class 1 recommendation that SGLT2 inhibitors be used in patients with diabetes at risk of cardiovascular events to reduce hospitalizations for heart failure, major cardiovascular events, end-stage renal dysfunction, and cardiovascular death. And then SGLT2 inhibitors were also recommended in patients with type 2 diabetes mellitus, heart failure with reduced ejection fraction, and heart failure with reduced ejection fraction in order to reduce hospitalization for heart failure and cardiovascular death. DPP-4 inhibitor saxagliptin was not recommended in patients with heart failure. So this was Class 3. So it was a consensus recommendation. Sorry, this one was not to be class 3. Recommendation for management of heart failure with iron deficiency anemia. So there's a class 1 recommendation that all patients with heart failure are periodically screened for anemia and iron deficiency with a full blood count, serum ferritin concentration, and transparent saturation. And there was a class 2A recommendation that intravenous iron supplementation with ferric carboxymaltose should be considered in symptomatic heart failure patients recently hospitalized for heart failure with ejection fraction less than or equal to 50 and iron deficiency, defined as ferritin levels less than 100 nanogram per mil or serum ferritin 100 to 299 nanogram per mil with TSAT of less than 20%. This is to reduce the risk of hospitalization. And the treatment of anemia in heart failure with erythropoietin-stimulating agents is not recommended in the absence of other indication for this therapy. This was class 3, so it's not to be done. For heart failure with cancer, it is recommended that cancer patients at increased risk of cardiotoxicity, which is defined by a history or risk of cardiovascular disease, previous cardiotoxicity, or exposure to cardiotoxic agents, undergo cardiovascular evaluation before scheduled anti-cancer therapy, preferably by a cardiologist with experience or interest in cardio-oncology. And class 2A recommendation was made for treatment with ACE inhibitor and beta blocker, preferably carvedilol, and that this should be considered in cancer patients who develop LV systolic dysfunction, defined as 10% or more decrease in LVEF, and to a value of lower than 50% during anthracycline chemotherapy. Class 2A recommendation was also made that a baseline cardiovascular risk assessment should be considered in all cancer patients scheduled to receive a cancer treatment with potential to cause heart failure. For heart failure with amyloidosis, there was a class 1 recommendation that tafamidis will be used in patients with genetic testing proving HET, RCA, cardiac amyloidosis, and NYHA class 1 or 2 symptoms to reduce symptoms, cardiovascular hospitalization, and mortality. Tafamidis was also recommended in patients with WTTR cardiac amyloidosis and NYHA class 1 or 2 symptoms to reduce symptoms, CV hospitalization, and mortality. So what's recommended both in the HTTR and the WTTR cardiac amyloidosis. Lastly, in the diagnosis of heart failure, for the 2021 guidelines, there was a class 2B recommendation that invasive coronary angiography be considered in patients with heart failure of reduced ejection fraction with an intermediate to high pretest probability of coronary artery disease and the presence of ischemia on non-invasive stress tests. In previous guidelines, which was the 2016 guidelines, this was a class 2A recommendation, but it was reduced to class 2B in the 2021 guidelines. And also, CT coronary angiogram should be considered in patients with low to intermediate pretest probability of coronary artery disease or those with equivocal non-invasive stress tests in order to rule out coronary artery disease. So the recommendation made for this in the previous 2016 guideline was class 2B, but it was bumped up to a class 2A recommendation in the 2021 guidelines. And also In device therapy in heart failure with reduced ejection fraction, there was a class 1 indication that for primary prevention, an ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure, and an EF of less than or equal to 35%, despite 3 months of optimal medical therapy, provided they are expected to survive substantially longer than 1 year with good functional status, and they have dilated cardiomyopathy. So in 2016, a class 1 recommendation was made for this. However, in 2021, it was reviewed to class 2A, where an ICD should be considered to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure of a non-ischemic etiology and an LV ejection fraction of less than or equal to 35%, despite 3 months of optimal medical therapy, provided they are expected to survive substantially longer than 1 year with good functional status. Still on device therapy, for 2021, CRT, cardiac resynchronization therapy, should be considered for symptomatic patients with heart failure in sinus rhythm with a QRS duration of 130 to 149 meters milliseconds with and left bundle branch block QRS morphology, and with an LVEF less than or equal to 35%, despite optimal medical therapy in order to improve symptoms and reduce morbidity. So the recommendation was reduced from class 1 to class 2A. Also, with patients with left ventricular ejection fraction less than or equal to 35, who have received conventional pacemaker or an ICD and subsequently developed worsening heart failure despite optimal medical therapy, and who have a significant proportion of RV pacing, should be considered for an upgrade to a cardiac resynchronization therapy. The recommendation for this was class 2A. So those who had previously been given a pacemaker, conventional pacemaker or ICD, but had developed worsening symptoms can be considered for upgrade to a CRT. Class 2A recommendation was made for that. Now, recommendations for patients with acute heart failure. In 2021, the recommendation was class 2A for the use of a combination of loop diuretic with a thiazide type diuretic in patients with resistant edema who do not respond to an increase in loop diuretic doses. Previously in 2016, the recommendation was class 2B. And then in patients with acute heart failure with systolic blood pressure more than 110 millimeter mercury, IV vasodilators may be considered as initial therapy to improve symptoms and also reduce congestion. The recommendation for this was reduced from class 2A to class 2B. The routine use of opiates is not recommended unless in selected patients with severe intractable pain or anxiety. So the recommendation for this is class 3. So opiates are not recommended for use in acute heart failure, except if they are in intractable or severe pain and anxiety. Previously, it was a class 2B, but now it's a 3. And then short-term mechanical circulatory support should be considered in patients with cardiogenic shock as a BTR, BTD, BTB. Further indications include treatment of the cause of cardiogenic shock or long-term mechanical support or transplantation. This recommendation was class 2A, but in the 2016, there was a class 2B for the use of short-term mechanical circulatory support in refractory cardiogenic shock. And this was dependent on the patient's age, comorbidities, and neurological function. For patients with heart failure and atrial fibrillation, drugs are recommended in preference to vitamin K antagonist in patients with heart failure, except those with moderate or severe mitral stenosis or mechanical prosthetic valves. That's a class 1 indication, recommendation. And then beta blockers should be considered for short and long-term rate control in patients in heart failure with atrial fibrillation. That's a class 2A. Previously, it was class 1. Also, in cases of a clear association between paroxysmal and persistent atrial fibrillation and worsening of heart failure symptoms, which persist despite medical therapy, catheter ablation should be considered for the prevention or treatment of atrial fibrillation. The recommendation for this was class 2A, whilst in 2016, there was a class 2B recommendation for AV node catheter ablation to control heart rate and relieve symptoms in patients who are unresponsive or intolerant to intensive pharmacological control therapy. So now it is a class 2A recommendation, ablation and atrial fibrillation in heart failure. For patients with heart failure and chronic coronary syndromes, coronary revascularization should be considered to relieve persistent symptoms of angina or an angina equivalent in patients with HFrEF, chronic coronary syndromes, and chronic coronary anatomy suitable for revascularization, despite optimal medical therapy, including anti-anginal medications. So those who had persistent symptoms despite optimal medical therapy, recommendation of class 2A was made for coronary revascularization. Previously, there was a class 1 recommendation for revascularization in patients with persistent angina, but now it's a class 2A for those with HFrEF and with chronic coronary syndromes and coronary anatomy suitable for revascularization. For patients with heart failure and diabetes, there's a class 1 recommendation for use of SGLT2 inhibitors, and they are to reduce the risk of cardiovascular events and to reduce hospitalization for heart failure, major cardiovascular events, and end-stage renal dysfunction or cardiovascular death. So the SGLT2 inhibitors have a class 1 indication they use for patients with heart failure and diabetes. So we've already gone through this definition of heart failure and categorizing it into heart failure reduced, mildly reduced, and preserved ejection fraction. So we are now going to go through the various algorithms for the diagnosis and diagnostic algorithm for heart failure. So if you suspect a patient has heart failure, you identify the risk factors the person has and also based on the symptoms and signs, as well as any abnormality on the ECG. You'd be required to do an NT-proBNP or a BNP. And if the NT-proBNP is greater than or equal to 125 picogram per ml, then heart failure, or if heart failure is strongly suspected or proBNP is unavailable, you can go ahead to do echocardiography. When you do your echocardiography, it will help you to determine the phenotype of the heart failure if you have abnormal findings. And that will help you to classify as heart failure with reduced ejection fraction, mildly reduced ejection fraction, or with preserved ejection fraction. And then you'd also want to go ahead to determine the etiology and commence treatment. However, if after the suspicion, your NT-proBNP is low and not suggestive of heart failure, you'd go ahead to assess for other possible causes. Or if your echocardiogram is also normal, you also would want to go ahead and assess what other possible causes of the symptoms, as heart failure will be unlikely in these patients. So this is the diagnostic algorithm we are going to use for a patient with suspected heart failure. And there are several possible etiologies of heart failure, and they include coronary artery disease, hypertension, valvular heart disease, arrhythmias, and cardiomyopathies. And they also include congenital heart disease, infective endocarditis, drug-induced, and the use of chemotherapy agents and also immune modulators. And then also infiltrative disease like amyloidosis, sarcoidosis, and other neoplasias. So based on your clinical suspicion, there are some specific investigations you may need to do to determine the exact etiology. And they range from cardiac imaging to other genetic testing, as well as right or left heart catheterization and toxicology. So depending on what you suspect, based on your history and assessment of physical assessment of the patient, you determine which further investigations need to be done. So the recommended diagnostic tests, these are the recommendations for them. So pro-BNP, NT-proBNP or BNP, there's class 1, level B. For 12-lead ECG, transthoracic echocardiography, chest X-ray, and routine blood tests, which include full blood count, electrolytes, renal function tests, thyroid function, fasting glucose, HbA1c, lipids, and iron status. The recommendation is class 1C. So these are the basic tests that you may consider doing for a patient with suspected chronic heart failure. And then the recommendations for specialized tests to in patients with chronic heart failure to detect reversible or treatable causes of heart failure. For cardiac MRI, there's a class 1C recommendation for the assessment of myocardial structure and function in those with poor echocardiogram windows. Your cardiac MRI is also recommended for the characterization of myocardial tissue in suspected infiltrative disease, Fabry's disease, inflammatory disease like myocarditis, LV non-compaction, amyloid, sarcoid, iron overload, or hemochromatosis. So the recommendation for use is 1C in these conditions, as well as 1C for those whose echocardiogram acoustic windows are poor. And 2A level C, you may use cardiac MRI with LGE, which is the late gadolinium enhancement, for patients with dilated cardiomyopathy to distinguish between ischemic and non-ischemic myocardial damage. That's the class 2A level C. For invasive coronary angiography, this is in those who are considered eligible for potential coronary revascularization. Invasive coronary angiography is recommended in patients with angina despite pharmacological therapy or symptomatic ventricular arrhythmias. It's class 1 level B to use invasive coronary angiography for those with persistent angina or those with symptomatic ventricular arrhythmias. And then invasive coronary angiography may be considered in patients with heart failure with reduced ejection fraction, with an intermediate to high pretest probability of coronary artery disease in the presence of ischemia or non-invasive stress tests. So this is a class 2B level B. For non-invasive testing, CT coronary angiogram should be considered in patients with low to intermediate pretest probability for coronary artery disease or those with equivocal non-invasive tests in order to rule out coronary artery stenosis. So where their risk is low to intermediate based on their pretest probability score, and their non-invasive tests were equivocal, you may do a CT coronary angiogram. However, where the risk is intermediate to high and there's presence of ischemia in non-invasive stress tests, the class 2B level B evidence is for invasive coronary angiography instead. Non-invasive tests, non-invasive stress imaging, such as cardiac MRI, stress echocardiography, SPECT, and PET, may be considered for the assessment of myocardial ischemia and viability in patients with coronary artery disease who are considered suitable for coronary revascularization. That's a class 2B level B. Exercise testing may be considered to detect reversible myocardial ischemia and investigate the cause of dyspnea. This is class 2B level C. You may perform exercise stress tests to detect reversible ischemia and also evaluate the cause of dyspnea. Cardiopulmonary exercise testing. So cardiopulmonary exercise testing is recommended as part of the evaluation for heart transplantation and or mechanical circulatory support. That's a class 1 level C recommendation. Cardiopulmonary exercise testing should be considered to optimize prescription of exercise training. And that's a class 2A recommendation. The level of evidence is C. And then cardiopulmonary exercise testing should be considered to identify the cause of unexplained dyspnea and or exercise intolerance. That's also a class 2A recommendation. Right heart catheterization. So there's a class 1 recommendation for the use of right heart catheterization in patients with severe heart failure being evaluated for heart transplantation and or mechanical circulatory support. And there's a class 2A recommendation for its use in patients where heart failure is thought to be due to constrictive pericarditis, restrictive cardiomyopathy, and congenital heart disease and high output states. Then same class 2A recommendation where in patients who are considered with probable pulmonary hypertension, assessed by echo in order to confirm the diagnosis and assess its reversibility before the correction of valve or structural heart disease. So where echo has suggested pulmonary hypertension, there's a class 2A recommendation to confirm this with right heart catheterization before to assess its reversibility before correction with surgical intervention. Heart catheterization may also be considered in selected patients with heart failure with preserved ejection fraction to confirm the diagnosis. And this is a class 2B recommendation. For amyloidosis, endomyocardial fibrosis, endomyocardial biopsy should be considered in patients with rapidly progressive heart failure despite standard therapy when there's a probability of a specific diagnosis which can be confirmed only in myocardial samples. So we may consider endomyocardial biopsy, especially in rapidly progressing heart failure. And the level of recommendation is class 2A. So we went through the diagnostic algorithm where we had suspected patients. We took our history, we did our examination, and then we may have done an ECG and may have found an abnormality, which will cause us to do an NT-proBNP or a BNP. And if this was elevated or they were unavailable, we'll go and do an echocardiogram. And if the echocardiogram detected an abnormality, we'll then describe the phenotype of the heart failure and then manage appropriately. So we are now going on to the management of heart failure. And we classify them into heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. So we're going to start with an algorithm for the management of patients with heart failure with reduced ejection fraction. So there's class 1 recommendation for the use of ACE inhibitors or ANI, beta blocker, mineralocorticoid receptor antagonists, SGLT2 inhibitors, dapagliflozin and empagliflozin, and loop diuretic for fluid retention. So we call them the 4 pillars or the 4 horsemen, where you have the ACE or ANI, the beta blocker, the MRA, and the dapagliflozin and empagliflozin being the disease-modifying medications, and the loop diuretic for symptomatic relief of fluid retention. There's class 1 recommendation for the use of these agents. Then you come down to, so that's for patients with reduced ejection fraction. Then you sub-classify, so those that, despite this optimal medical therapy, they have their heart failure, their ejection fraction persistent to be less than 35%, and their QRS duration is also less than 130 milliseconds. Then where appropriate, you may consider an ICD for these people. So either for those who have ischemic etiology, the recommendation is class 1, and those that have non-ischemic etiology, the recommendation is class 2A. For those whose ejection fraction is greater than 35%, or device therapy is not indicated or appropriate, you do not use device therapy for them. For those in sinus rhythm, yet have their ejection fraction less than or equal to 35%, and a QRS duration of more than or equal to 130 milliseconds. CRT D or P is recommended. If the QRS duration is 130 to 149, it's a class 2 indication. If the QRS class 2A recommendation, if the QRS is more than or equal to 150 milliseconds, it's a class 1 recommendation. For all 3 of these, if the patient persists to be symptomatic, then you consider therapies with class 2 recommendations. So we have the pharmacotherapy and then device therapy. Device therapy is considered with those with ejection fraction less than or equal to 35%. And it's also based on the QRS duration. So if the QRS duration is less than 130, you consider an implantable cardioverter defibrillator. If the QRS duration is more than or equal to 130 milliseconds, and the patient is in sinus rhythm, you consider a cardiac resynchronization therapy, either CRTD or CRTP. And this is based on how prolonged the QRS duration is. So for patients with NYHA class 2 to 4 heart failure with reduced ejection fraction, the following recommendations were made. There's recommendation for the use of ACE inhibitor, beta blocker, MRA, and SGLT2 inhibitor for the reduction of risk of heart failure hospitalization and death. And all these were class 1 recommendations with level A evidence. And then there was recommendation for the use of sacubitril valsartan, which is an ANI, angiotensin receptor neprilysin inhibitor, as a replacement for ACE inhibitors in patients with heart failure with reduced ejection fraction to reduce the risk of hospitalization and death. And it's a class 1 recommendation with a level B evidence. So here are some doses that were recommended to be started for the various patients. For the MRA, the options were spironolactone and eplerenone. So either of them could be used. Right. Evidence-based doses of. In the cases where you had to use digoxin and or hydralazine isosorbide dinitrate, these were the starting doses of 62.5 microgram daily for digoxin with the maximum dose of 250 microgram daily. And for hydralazine, it was 57.5, with hydralazine being 37.5 milligram TID and isosorbide 20 milligram TID, starting dose. So there were other pharmacological treatments that were indicated in selected patients with HFrEF with NYHA class 2 to 4. So in the case of loop diuretics, the diuretics were recommended in patients with symptoms and or signs of congestion to alleviate the symptoms, improve exercise capacity, and reduce heart failure hospitalization. The recommendation was class 1, evidence level C. And then ARB is recommended to reduce the risk of hospitalization and CV death in symptomatic patients unable to tolerate ACE or ANI. Patients should also receive a beta blocker and an MRA. So where you're unable to use an ACE or an ANI, then you would want to use an angiotensin receptor blocker. That's also class 1, level B. For ivabradine, it should be considered in symptomatic patients with heart failure with EF less than 35%, in sinus rhythm, and a resting heart rate of more than or equal to 70 beats per minute, despite treatment with an evidence-based dose of beta blocker or maximum tolerated dose below that, ACE inhibitor, and an MRA to reduce the risk of hospitalization. So where you fail to achieve target heart rate despite the use of the recommended disease-modifying drug, and especially the evidence-based dose of a beta blocker or the maximum tolerated dose, then you may add on ivabradine, provided the patient is in sinus rhythm. It was a class 2A recommendation with evidence level B. And then ivabradine should be considered in symptomatic patients with EF less than or equal to 35%, in sinus rhythm, and a resting heart rate of more than or equal to 70 beats per minute, who are unable to tolerate or have contraindications to beta blocker to reduce the risk of heart failure, hospitalization, and CV death. A patient should also receive ACE or ANI and an MRA. So if the patient is unable to tolerate or there's contraindications to beta blocker use, you may also use ivabradine. So it may be used as on its own or to optimize rate control when you have used maximum or maximum tolerated dose of a beta blocker. So for soluble guanylate cyclase stimulator, vericiguat, it may be considered in patients with class 2, NYHA class 2 to 4, who have had worsening heart failure despite treatment with the ACE or ANI, beta blocker, and an MRA to reduce the risk of CV mortality and hospitalization. So the evidence was was class 2B. And for hydralazine and isosorbide dinitrate, there was a class 2A recommendation with level B evidence for its use in self-identified Black patients with EF less than or equal to 35%, or with EF less than 45%, combined with a dilated left ventricle in NYHA class 3 to 4, despite treatment with an ACE inhibitor or a beta blocker and an MRA to reduce the risk of hospitalization and death. There was also a class 2B recommendation for its use in patients with symptomatic heart failure with reduced ejection fraction who cannot tolerate any of an ACE or ARB or ANI. because they are contraindicated to reduce the risk of death. Digoxin may be considered in patients with symptomatic heart failure with reduced ejection fraction and sinus rhythm, despite treatment with an ACE inhibitor or ANI or beta blocker and MRA to reduce the risk of hospitalization, both all-cause and HF hospitalization. The recommendation for this was okay. So in terms of the management for heart failure with reduced ejection fraction, we have established that the 4 pillars of the management was the ACE or ANI, in the absence of which you may use an ARB, a beta blocker, a mineralocorticoid receptor antagonist, and SGLT2 inhibitor. Those were the disease-modifying medications that we were to use. And then for symptomatic relief, diuretics, which were basically the loop diuretics. And then if the patient persisted to have an ejection fraction less than or equal to 35%, if the QRS duration was less than 130, you consider an ICD. If the QRS duration was more than 130, you consider CRTD or P. And then the level of evidence was based on whether it was 130 to 149 or greater than or equal to 150. And if all these failed, other further pharmacological interventions include the use of vericiguat, digoxin, hydralazine isosorbide dinitrate to help to reduce the risk of hospitalization and cardiovascular events. So we are going to go on to the strategic phenotypic overview of the management of heart failure with reduced ejection fraction. So that is what I have said. It has summarized it here nicely. The drugs that reduce mortality for all patients are the ACE, ANI, beta blockers, mineralocorticoid receptor antagonists, and the SGLT2 inhibitors. And to reduce, they also may reduce hospitalization or mortality for selected patients. In the case of volume overload, you use diuretics. If they are in sinus rhythm with left bundle branch block with QRS duration of more than 150 milliseconds, you consider a CRTP or D. If there's ischemic etiology, you consider ICD. If a sinus rhythm with the LBB morphology, QRS duration 130 to 149 milliseconds, or non-LBB morphology with greater than or equal to 150 milliseconds, you consider CRT, P or D. And if it is non-ischemic etiology, you may consider ICD. If the patient has atrial fibrillation, you consider, and you have to anticoagulate the patient based on their CHA2DS2. And then you also consider digoxin or pulmonary vein isolation in these cases. These may reduce hospitalization and mortality for selected patients. If the patient has coronary artery disease, coronary artery bypass grafts may be considered, especially those who remain symptomatic despite optimal medical therapy. And if the patient has iron deficiency anemia, intravenous ferric carboxymaltose should be considered in these patients. Where there's aortic stenosis, valve repair, either using Savro or Tabi, should be considered. Heart failure with reduced ejection fraction. For mitral regurgitation, especially secondary mitral regurgitation, you can do mitral valve repair, end-to-end mitral valve repair. Patients whose heart rate persists to be above 70 beats per minute, you can consider adding on ivermectin. And for those with the black race who persist to be symptomatic and have their EF less than or equal to 35%, you may use hydralazine isosorbide combination for them. And for selected patients with advanced heart failure, there's a recommendation for heart transplantation, and then mechanical circulatory support, as well as long-term mechanical circulatory support as the destination therapy. So the mechanical circulatory support may be used as a bridge to candidacy or a bridge to transplantation. Okay. So we are going to discuss ICD in heart failure. So its recommendation as secondary prevention, there's a class 1 level A recommendation for an ICD be recommended to reduce the risk of sudden death and all-cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability and who are expected to survive for more than 1 year with good functional status in the absence of reversible causes or unless the ventricular arrhythmia has occurred less than 48 hours after an MI. So if there's high risk of sudden cardiac death and the patient has a high expected survival of more than 1 year with a good functional status, there's a class 1 recommendation to put in an ICD for the patient. And then for as primary prevention, an ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure, NYHA class 2 to 3 of an ischemic etiology, unless they've had an MI 40 days prior and an LVEF of less than or equal to 35%, despite more than 3 months of optimal medical therapy, provided they are expected to survive substantially longer than 1 year with good functional status. So for patients who have whose heart failure is of ischemic etiology and who have an EF less than or equal to 35% despite optimal medical therapy, with risk of sudden death or all-cause mortality, there's an indication for the use of ICD, class 1A, class 1 level A in the recommendation. Still on the primary prevention with ICD, it should be considered to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure, class 2 to 3, NYHA, of non-ischemic etiology, and an LVEF of less than or equal to 35%, despite 3 or more months of medical therapy, provided they are expected to survive substantially longer than 1 year with good functional status. The recommendation was class 2A for primary prevention in heart failure of non-ischemic etiology. And then class 2A recommendation for carefully evaluated patients by an experienced cardiologist before generator replacement because management goals, the patient needs and clinical status may have changed. So if the patient has had an ICD and there's a need to replace the generator, there's a need to have the patient assessed again to ensure that the management goals and patient needs and clinical status give indication for the use of an ICD to inform the generator change. The recommendation for that is class 2A. A wearable ICD may be considered for patients with heart failure who are at risk of sudden death for a limited period or as a bridge to an implanted device. The recommendation for this is class 2B. ICD implantation is not recommended within 40 days of a myocardial infarction, as implantation at this time does not improve prognosis. This is class 3 recommendation, should not be done. An ICD therapy is not recommended in patients with NYHA class 4 with severe symptoms refractory to pharmacological therapy, unless they are candidates for CRT, ventricular assist device, or cardiac transplantation. That's also class 3. So now we go on to cardiac resynchronization. So we are on the recommendations for device therapy now. And we've discussed the recommendations for ICD in as primary prevention and also as secondary prevention. And we are moving on to cardiac resynchronization therapy for patients with heart failure. There's a level class 1 recommendation for the use of CRT in symptomatic patients with heart failure in sinus rhythm with a QRS duration of more than or equal to 150 milliseconds and left bundle branch block QRS morphology, and with LVEF less than or equal to 35%, despite optimal medical therapy in order to improve symptoms and reduce morbidity and mortality. There's a class 2A recommendation for its use in patients whose QRS duration is 130 to 149 with LBB morphology and EF less than or equal to 35, also to improve symptoms and reduce morbidity. And a class 2A recommendation for its use in patients with symptomatic patients with heart failure in sinus rhythm with a QRS duration greater than or equal to 150 milliseconds and non-LBB QRS morphology with LVEF less than or equal to 35. This is also to improve symptoms and reduce morbidity. So in this use, you are going to consider the QRS duration, the QRS morphology, and the ejection fraction. So you have a heart failure patient with LBB QRS morphology. If the QRS duration is more than or equal to 150 milliseconds, that's a class 1A recommendation for CRT. If the QRS duration is 130 to 149, the recommendation is class 2A. However, EF is less than or equal to 35%. The QRS morphology is non-left bundle branch block, but the duration is more than or equal to 150 milliseconds. There's also a class 2A recommendation for the use of cardiac resynchronization therapy. CRT may be considered for patients with heart failure with sinus rhythm with a QRS duration of 130 to 149 milliseconds and non-LBB QRS morphology, and with LVEF less than or equal to 35% despite optimal medical therapy in order to improve symptoms and reduce mortality. So that's class 2B. CRT rather than RV pacing is recommended for patients with heart failure regardless of the NYHA class or QRS with who have an indication for ventricular pacing for high degree AV block in order to reduce mortality. This includes patients with atrial fibrillation. So where you would need to, there's indication for ventricular pacing, either for a higher degree AV block or you'd rather do a CRT than an RV pacing. Then recommendation is class 1 and the level of evidence is A. So patients with HFmrEF, irrespective of their QRS with or NYHA class, who have indication for ventricular pacing, CRT is preferred over RV pacing. For patients with LVEF less than or equal to 35%, who have received conventional pacemaker or an ICD and subsequently develop worsening heart failure despite optimal medical therapy and who have a significant proportion of RV pacing, should not be considered for upgrade, should be considered for upgrade to CRT. So those who have had previous pacemaker, conventional pacemaker or ICD, and have a high proportion or significant proportion of RV pacing, they should be considered for an upgrade to CRT. The recommendation is class 2A. And CRT is not recommended in patients with QRS duration less than 130 milliseconds who do not have an indication for pacing due to high degree AV block. And that's class 3. So we are now going on to the treatment of heart failure with mildly reduced ejection fraction. So diuretics for the management of congestion in these patients is class 1 to alleviate symptoms and signs. ACE inhibitors, ARBs, beta blockers, mineralocorticoid receptor antagonists, and ANIs are also considered as class 2B recommendation for heart failure with mildly reduced ejection fraction to reduce the risk of hospitalization and death. I don't know if you want me to go through this. This has to do with the assessment for heart failure with preserved ejection fraction.
Yeah, I think you still have time. 6:13. I don't know how many slides more you have, but you have about, if you can do it and finish in 20 minutes max so that there can be questions and contributions.
Okay, so I may skip this part and go on.
Oh, okay.
Okay, so this is just talking about the objective assessment for structural, functional, and serological abnormalities consistent with the presence of left ventricular diastolic dysfunction or raised left ventricular filling pressures. So we have to assess the LV mass index, the relative wall thickness for the LV geometry, and then the left atrial volume index if it is more than 34 mils per meter squared, and then the E to E prime ratio, the tissue Doppler, and your serological test, that's the NT-proBNP or the BNP. So the echocardiographic assessment you did was to determine diastolic dysfunction and also assess the left atrial pressures. And then the NT-proBNP will also determine heart failure. So up to 20% of patients with invasively proven heart failure with preserved ejection fraction have natriuretic peptides below diagnostic threshold, particularly in the presence of obesity. So you may or may not have your NT-proBNP being elevated, even though the person may have heart failure with preserved ejection fraction. And you also will want to assess your pulmonary artery systolic pressure and your tricuspid regurgitation velocity at rest. So these are the parameters that you need in your assessment of such patients. For treatment with patients with heart failure with preserved ejection fraction, in terms of screening, there's a class 1 recommendation to screen for and then treat the etiologies and cardiovascular and non-cardiovascular comorbidities in these patients. So you have to look for these comorbidities, and then you have to treat these comorbidities in these patients. You also have to determine the etiology of the heart failure with the preserved ejection fraction and treat the underlying etiology. For diuretics, they are recommended for congested patients in heart failure with preserved ejection fraction for the alleviation of symptoms. So this is class 1 recommendation, treating the underlying cause and comorbidities, looking for and treating the underlying cause and comorbidities, as well as symptomatic relief using diuretic therapy. So when it comes to recommendation for primary prevention of heart failure in patients who are at risk for its development, there was a class 1 recommendation for the following. Treatment of hypertension is recommended to delay the onset of heart failure and prevent heart failure hospitalization. Treatment with statins for those with high risk of CVD or those with CVD in order to prevent or delay the onset of heart failure and prevent heart failure hospitalization. Then SGLT2 inhibitors for patients with diabetes at high risk of CVD or those who have established CVD to prevent hospitalizations. And then counseling against sedentary habits, obesity, cigarette smoking, alcohol abuse was also recommended to delay the onset of heart failure. So for primary prevention, it was treatment of the underlying cardiovascular risk factors like hypertension, dyslipidemias, and diabetes mellitus, and also addressing the lifestyle risk factors to prevent development of heart failure or its hospitalization. And then they also recommended multidisciplinary interventions for the management of chronic heart failure. So it's recommended that heart failure patients are enrolled into a multidisciplinary heart failure management program, and also recommended that self-management strategies are taught to reduce the risk of hospitalization, and then also home-based or clinic-based programs instituted to improve outcomes. So these are all class 1, level A. And then the role of the use of vaccinations, the influenza and pneumococcal vaccination should be considered. That's the class 2A, level B recommendation. So important characteristics and components in heart failure management program. It's patients or person-centered, multidisciplinary, and the focus of the program should be flexible. And should be to prevent disease progression, symptom control, and maintain patients in their preferred place of care for end-stage heart failure. And then competent and professionally educated staff. And then they should encourage patient or carer engagement in their understanding and management of their condition. When you're planning a heart failure management program, these are the things it must consist of. So the program will also seek to optimize the management, lifestyle choices, pharmacological and device therapy, and then patient education with special emphasis on self-care and symptom management should be undertaken, as well as provision of psychosocial support to patients and their caregivers, and follow-up after discharge, either clinic or home visits or telemedicine or telemonitoring can be done. And then easy access to health care, especially to prevent and manage decompensation. Then assessment of an unexplained change in the weight, nutritional or functional status, quality of life, sleep problems, psychosocial problems, and other findings can be undertaken as part of the heart failure management program. And then access to advanced treatment options, supportive and palliative care. So you should be able to link your heart failure management program to access to advanced treatments such as transplant, mechanical circulatory support, device therapy, and then supportive and palliative care should also be part of your scope. So exercise is recommended for all patients who are able in order to improve exercise capacity, quality of life, and reduce heart failure hospitalization. That's class 1, level A. And then exercise should be supervised exercise-based cardiac rehabilitation program should be considered in patients with more severe disease, frailty, or with comorbidities. That's class 2A. So there's a role of telemedicine in heart failure management. So like non-invasive home telemonitoring can be done, class 2B, and monitoring of pulmonary artery pressure using a wireless hemodynamic monitoring system may be considered in patients who are symptomatic in order to improve clinical outcomes. That's a class 2B recommendation. So advanced heart failure, the criteria for the advanced heart failure is all of the following, despite optimal medical therapy. So the person would have severe or persistent symptoms, class 3 or 4 NYHA, then severe cardiac dysfunction defined by EF less than or equal to 30, isolated RV failure, such as in arrhythmogenic RV cardiomyopathy, non-operable severe valve abnormalities or congenital abnormalities, and persistently or increasing BNP or NT-proBNP, and severe diastolic dysfunction or structural LV abnormalities. So these should be present. And then episodes of pulmonary or systemic congestion requiring high IV doses, IV diuretics, or episodes of low output requiring inotropes or vasoactive drugs, or malignant arrhythmias causing more than one unplanned visit or hospitalization in the last 12 months. Then severe impairment of exercise capacity with inability to exercise or low 6-minute walk tests, that's less than 300 meters, or peak oxygen consumption of less than 12 ml per kilogram per minute, or less than 50% predicted value estimated to be of cardiac origin. So you need to have all of these present to be able to classify a patient as advanced heart failure. So there's an algorithm for the treatment of patients with advanced heart failure, and it's essentially based on their interagency registry for mechanically assisted circulatory support. So there's a role for short-term mechanical circulatory support, and I said it could be as a bridge to transplant, a bridge to device therapy, sorry, a bridge to recovery, a bridge to transplantation, a bridge to decision making. So class 2 recommendation, 2A recommendation, if they have Intermax 1, 2, 3 to 4. You can use short-term mechanical circulatory support. If the person has brain damage and persists to have brain damage or irreversible end organ damage, you'd have to consider its withdrawal. The person has cardiac, neurological, and end organ recovery, then you would wean off the mechanical circulatory support. And if the person has neurological and end organ recovery, but no cardiac recovery, then you would have to assess for contraindication to heart transplantation. If they have contraindication because it is reversible, then you would consider a left ventricular assist device as a bridge to candidacy. And then if it is not potentially reversible, then you consider a left ventricular assist device as a destination therapy. If the person has Intermax 4, which is greater than 4, which is stable ambulatory, but the patient is high risk, you assess for contraindication to heart transplantation, and then you proceed per such. But if the patient is not high risk, then you give advanced therapies such as left ventricular heart transplant, left ventricular assist device. Those ones can be fed, and then you monitor closely if the patient is not high risk. So if you have a patient who has advanced heart failure, these are the therapeutic options available for you. Heart transplantation and mechanical circulatory support as either short-term or long-term, and then left ventricular assist device also. So somebody has written a lot on the screen, so it's making reading difficult. I don't know if we can clear it. So for eligibility for left ventricular assist device, you're dealing with patients who have persistence of severe symptoms despite optimal medical and device therapy without severe right ventricular dysfunction and or severe tricuspid regurgitation, and those who have stable psychosocial background and absence of major contraindications, and who have at least one of the following. So if their EF is less than 25% and they're unable to exercise, perform if they're able to perform cardiopulmonary testing, their oxygen consumption is low or lower than the predicted value, or the patient has had 3 or more hospitalizations in the past year without obvious precipitating cause, or a patient is dependent on inotropic support of temporary mechanical circulatory support, or patient has progressive end organ dysfunction due to reduced perfusion and not and not to inadequately low ventricular filling pressure, then the patient is a potential candidate for left ventricular assist device. For heart transplantations, indications include advanced heart failure, which we have discussed just a few minutes ago, and when there's no other therapeutic option except for left ventricular assist device, as well as a bridge to transplantation. So contraindications include active infection, severe peripheral arterial or cerebrovascular disease, pharmacologic irreversible pulmonary hypertension, malignancy with poor prognosis, and irreversible liver damage or irreversible renal dysfunction, or combined heart, liver, or heart kidney transplants may be considered in those patients. Other than that, it is contraindicated. So other contraindications include systemic disease with multi-organ involvement, serious comorbidity with poor prognosis, pre-transplant BMI greater than 35 kilograms per meter squared. So they recommend weight loss to achieve BMI of less than 35 kilograms per meter squared before heart transplantation. Then current alcohol or drug abuse, psychological instability that jeopardizes proper follow-up and intensive therapeutic regimen after heart transplantation, and insufficient social support to achieve compliant care in the outpatient setting. All these constitute contraindications to heart transplantations. So for patients with heart advanced,
yes, I think it's your screen that you are sharing. So maybe it's on your
no, someone is writing on their end. I don't know how they're able to do
okay.
that.
All right.
Yes.
So how many slides do you have more?
I could move to the 2023 updates.
Yeah.
Let me
We have
see.
someone who's going to talk to us on cardiac transplantation. So I think to
Okay.
allow time for questions from colleagues with respect to the heart failure, and we know you can move on to the emphasis on the heart failure, the ones that emphasize that, because we have someone who's going to do cardiac transplantation.
Okay, so then that's fine. So we've done the
Sorry, but
chronic.
please, Dr. Florence, we want to have the entire slide.
Okay, no problem.
Thank you.
So we have dealt with chronic heart failure. Another aspect was acute heart failure. So the diagnostic workup for new onset acute heart failure, it's also you have to assess the history, signs, symptoms, and then you perform an ECG, pulse oximetry, electrocardiography, initial laboratory investigations, which include troponins, creatinine, electrolytes, urea, nitrogen, TSA, liver function, sometimes D-dimer and procalcitonin, as indicated by the clinical presentation, and then chest X-ray, lung ultrasound, and other specific evaluations. And then from then, you can go on to do your natriuretic peptide testing. So if you do your NT-proBNP, the BNP, and the NT-proBNP is greater than or equal to 300, or BNP is greater than or equal to 100, then acute heart failure is confirmed. If they are less than these values, then it's unlikely to be acute heart failure. So if the acute heart failure is confirmed, then you proceed to do a comprehensive echocardiogram to try and determine the etiology. Okay. So as you're going to get the slides, you'll be able to tell which ones the diagnostic value for the various initial investigations for acute heart failure. Okay, so for the clinical presentation of acute heart failure, there are four main mechanisms. The patient may present as acutely decompensated heart failure, acute pulmonary edema, isolated right ventricular failure, or cardiogenic shock. And the mechanisms are as stated. And for the acutely decompensated heart failure, you have fluid accumulation and increased intraventricular pressure. For the pulmonary edema, you have fluid redistribution to the lungs, resulting in acute respiratory failure. And for the RV failure, you have increased central venous pressure and often systemic hypoperfusion. And for cardiogenic shock, you have systemic hypoperfusion. Most of them may be of insidious onset, but that of acute pulmonary edema is usually rapid. The RV failure and cardiogenic shock may also be rapid. And they may present in either wet or warm, dry and cold, or in any of the phenotypes, depending on the etiology or the clinical type of acute failure you are having. So, and the treatment will therefore be based on your ability to identify which of these 4 types the patient is presenting with. Oftentimes, there'll be room for diuretic use for peripheral and pulmonary congestion. Sometimes there's need for inotropic agents, especially in the acutely decompensated heart failure and the isolated right ventricular failure, as well as the cardiogenic shock. And then sometimes you may need short-term mechanical circulatory support in the management. So there's fluid congestion or overload, and then there may be hypoperfusion. If these persist, then you give loop diuretics and you consider inotropes. If there's hypoperfusion, if there's no hypoperfusion, loop diuretics class 1. If there's relief of congestion, you continue to optimize medical therapy. However, if there's no relief, you consider optimizing diuretic doses and or combining diuretics. And then if there's diuretic resistance or end-stage renal failure, you consider renal replacement therapy or palliative care. But if there's no diuretic resistance, you continue to optimize medical therapy. In those that needed inotropic support, if the hypoperfusion and congestion is relieved, you proceed to optimize medical therapy. If it persists, you consider vasopressors. And then if it persists to be organ damage, you consider mechanical circulatory support, renal replacement therapy, or palliative care in those cases. So for the pulmonary edema, there's room for oxygen, supplemental oxygen or ventilatory support. And then you consider their blood pressure. If it is sustained above 110 millimeter mercury, you do your diuretics and or vasodilators. However, if it is lower than that, and there are signs of hypoperfusion, you do your diuretics and or inotropes / vasopressors. Other than that, you just do your loop diuretics. And then if they respond, if there's congestion relief, you continue medical therapy. However, if they fail to respond, you consider renal replacement therapy, mechanical circulatory support, and other devices, or you consider palliative care. So that's it mainly for the acute heart failure. And if they have cardiogenic shock, depending on the etiology, if it is acute coronary syndrome with this mechanical complications, you consider emergency PCR surgical treatment. Other than that, you treat other specified causes, give a supplemental oxygen or ventilatory support where appropriate, consider inotropes or vasopressors where appropriate, and also consider short-term mechanical circulatory support. And if there's hypoperfusion and organ dysfunction, you'd maintain the mechanical circulatory support, consider renal replacement therapy or palliative care. And if they respond, you wean them off these agents and then continue treatment of the etiological cause and optimize their medical therapy. So essentially, you have to determine whether or not they are in shock and manage appropriately. And then identifying the acute etiology. It could be acute coronary syndrome, hypertensive emergency, arrhythmia, mechanical cause, pulmonary embolism, infections, or tamponade. So you have to assess for the possibility of these etiologies and then manage appropriately. Okay. Usually, how many minutes do I have left?
It's 6:37. So can you finish in? We need time for questions. So maybe maximum I can give you 15 minutes. We started 10 minutes late, so we can add that additional 10 minutes for the questions.
Okay. So the recommendations for the initial treatment of acute heart failure. So oxygen and ventilatory support, class 1 recommendation, if saturations are less than 90 or PO2 is less than 60 millimeter mercury, in order to correct hypoxemia. If intubation is recommended, or intubation is recommended if progressive respiratory failure persistent in spite of oxygen administration and non-invasive ventilation. Then if non-invasive positive pressure ventilation should be considered, non-invasive positive pressure ventilation should be considered in patients with respiratory distress and started as soon as possible in order to decrease respiratory distress and reduce the rate of mechanical endotracheal intubation. So that's a class 2A recommendation. So oxygen therapy in acute heart failure for correction of hypoxemia, and also intubate if they are in respiratory distress, non-invasive positive pressure ventilation to prevent the need for intubation is also to be considered. And for diuretics, intravenous loop diuretics for all acute heart failure patients who are admitted with fluid overload to improve symptoms. That's class 1. Then combination of loop diuretic with thiazide type diuretic should be considered for those with resistant edema not responding to the loop monotherapy. That's class 2A. And then use of vasodilators. If they have acute heart failure, systolic blood pressure sustained above 110 milliliter mercury, vasodilators may be considered as initial therapy to improve symptoms and reduce congestion. That's class 2B. For inotropic agents, they may be considered in patients with systolic blood pressure less than 90 millimeter mercury and evidence of hypoperfusion who do not respond to standard treatment, including fluid challenge, to improve peripheral perfusion and maintain organ function. That's class 2B. And then they are not routinely recommended due to safety concerns. So unless the patient is symptomatic, has symptomatic hypotension or evidence of hypoperfusion, then you wouldn't use them. So that's class 2A. They only to be used if the person has symptomatic hypotension with evidence of hypoperfusion. For vasopressors, preferably norepinephrine may be considered in patients with cardiogenic shock to increase the blood pressure and vital organ perfusion. That's a class 2B recommendation. And other drugs, so if thromboembolism prophylaxis with low molecular weight heparin is class 1 recommendation, and we do not use opiates routinely, except if they have severe pain or anxiety. So that's class 3. So those for the use of short-term mechanical circulatory support in patients with cardiogenic shock, it should be considered as a bridge to recovery, bridge to decision, bridge to bridge in patients who have cardiogenic shock or patients who have need for long-term mechanical circulatory support or transplantation. So that's class 2A. And you can also use intra-aortic balloon pump in patients who have aortic cardiogenic shock, also as a bridge therapy, including treatment of those with cardiogenic shock or long-term mechanical circulatory support or transplantation. Then intra-aortic balloon pump is not routinely recommended post-MI cardiogenic shock. So that's class 3. The cardiogenic shock is due to MI, you wouldn't use an intra-aortic balloon pump. So pre-discharge and early post-discharge follow-up, you should, class 1A recommendation for planned follow-up in 1 to 2 weeks after the discharge. And then also you recommend evidence-based oral medication. You transition them to oral before the discharge. That's also class 1. And then you have to ensure that they have been evaluated to exclude persistent signs of congestion before discharge, and you have optimized the oral treatment prior to discharge. So class 1 recommendation for these three. And if they have iron deficiency, you give them ferric carboxymaltose to improve symptoms and reduce hospitalization. That's a class 2B. So the comorbidities, atrial fibrillation, the recommendation is anticoagulation long-term based on the Chadba score, and that's class 1 level A. And they recommend drugs over vitamin K antagonists, except if due to mitral stenosis or mechanical prosthetic valves, that's class 1A. And then long-term treatment with an oral anticoagulant should be considered for stroke prevention. So based on their Chadba score, that's class 2A. Then rate control. Beta blockers are prioritized both for short and long-term rate control. Class 2A. Digoxin may be considered when the ventricular rate remains high despite the beta blockers, or when beta blockers are contraindicated or not tolerated. That's also class 2B, but the level of evidence is C. For cardioversion, you can do urgent electrical cardioversion in the setting of acute worsening of heart failure in patients presenting with rapid ventricular rates and hemodynamic instability. That's class 1, level C. And then cardioversion may be considered in patients in whom there's an association between atrial fibrillation and worsening heart failure symptoms despite optimal medical therapy. That's class 2, level B. Catheter ablation, class 2A recommendation, where in the case of paroxysmal AFib or persistent AFib, worsening heart failure symptoms despite medical therapy, you can consider catheter ablation to prevent or treat the atrial fibrillation. So for comorbidities, persons with chronic coronary syndromes with heart failure with reduced ejection fraction, coronary revascularization should be considered in patients with persistent angina, despite optimal medical therapy, including anti-anginal drugs. That's class 2A. And also coronary revascularization can be considered to improve the outcomes of these patients after careful evaluation of with risk-benefit ratios and individualized evaluation of the risk-benefit ratios. So that's class 2B. And then in left ventricular assist device candidates needing coronary revascularization, coronary artery bypass grafts should be avoided if possible. So if the person is on left ventricular assist device or is a candidate for left ventricular assist device, then you should avoid coronary artery bypass grafts. That's class 2A. However, you should consider CABG as the first choice revascularization therapy in patients who are suitable for surgery, especially if they have diabetes or multivessel disease. That's class 2A. And then PCI should be considered as an alternative to CABG based on a heart team evaluation and decision based on the surgical risk. That's class 2B. So either CABG or PCI. However, if the person is a candidate for left ventricular assist device, you would want to avoid a CABG. So for patients with aortic stenosis and mitral valve regurgitation, these are the recommendations. So if a person requires an aortic valve intervention, either a TAVI or a SAVR, you may do either of them in patients who have heart failure with severe high gradient aortic stenosis, as this will help reduce mortality and improve symptoms. It's a class 1 recommendation. And it is also recommended that the choice between the TAVI and SAVR be made by the heart team based on the individual risk benefits evaluation. And for secondary mitral regurgitation, you may do who need revascularization. CABG and mitral valve surgery should be considered. So that's class 2A. And then you can also do percutaneous edge-to-edge repair for those who are not eligible for surgery and not needing coronary revascularization, but are symptomatic despite medical therapy. That's 2A. Edge-to-edge percutaneous repair may also be considered for those who have secondary MR not eligible for surgery and are highly symptomatic, but do not fulfill criteria for reducing hospitalization. That's a class 2B. So those who fulfill criteria for achieving hospital reduction in hospitalization is a 2A recommendation. But those who do not have fulfill the criteria is 2B recommendation. For diabetes and heart failure, SGLT2 inhibitors are recommended. And then they are also recommended for patients who have type 2 diabetes with heart failure with reduced ejection fraction to reduce the risk of hospitalization and CV death. Both is a class 1A recommendation. For iron deficiency anemia, you should screen the patients periodically for anemia and iron deficiency. That's class 1. And then IV iron supplementation with ferric carboxymaltose should be considered in symptomatic patients with LVEF less than 45 and iron deficiency. And then and to alleviate the symptoms, that's class 2A. And then you should consider it in symptomatic heart failure patients who have been recently hospitalized for heart failure with EF less than 50 and iron deficiency states. So class 2A, if the EF is less than 40 and have an 45 and have an iron deficiency state, or class 2A, if the LVEF is less than 50 and have recently been hospitalized and have an iron deficiency state. For drugs causing heart failure, such as anthracycline chemotherapy, HER2 targeted therapies, VEGF inhibitors, multi-targeted kinase inhibitors, like the third generation BCR-ABL TKIs, nilotinib, dasatinib, proteasome inhibitors, immunomodulatory inhibitors, and combination of RAF and MEK inhibitors, as well as many other chemotherapy agents that pose a risk for heart failure. So many of them pose a risk for heart failure. So this is the algorithm for the management of cancer patients with heart failure. If they are receiving potential cardiotoxic treatments, before the cardiotoxic treatment, you'd want to assess the baseline risk, including clinical assessments, ECG, resting echocardiogram, cardiac biomarkers, and then assess also pre-existing heart failure or high-risk cardiovascular disease. Then you now grade them into low-risk patients and medium or high-risk patients. And during the cardiotoxic cancer treatment, you have increased surveillance with ECG and cardiac biomarkers during treatment for those with medium and high risk, and you reassess them at 3 months and 12 months after completion of the cancer therapy. And then for those who are low risk, you do a standard surveillance, which is intended every 3 months. And increased surveillance is every 1 to 4 weeks, and standard surveillance is every 3 months. And you reassess them at 12 months after completion of the cancer therapy. And after the treatment, for all of them, every 5 years, you following the therapy with established cardiotoxicity, you reassess them. And then you follow up by heart failure and cardio-oncology team for new heart failure or LV systolic dysfunction. So if they develop new heart failure, they'll have follow up by these people. So, pregnancy, I will skip that. I want to go to the 2023 updates so that we can have time for the questions, if that's okay, Eugene.
Yeah, Florence, yes, if you can do the 2023 update. The pregnancy is important, but you do the 2023 update because we
okay, so I just had a few more slides before the update. If you want me to the
okay, then I think colleagues will be okay with it. So you just finish that and let's go into the 2023.
Okay.
And I must admit yours is quite broad, so I think the colleagues will understand.
Okay, so for the management of patients with heart failure before and during pregnancy, so pre-pregnancy, there's counseling, including risk assessment and education. And then at pregnancy diagnosis or planning, you should have a cardiac assessment including clinical assessments, ECG, and echocardiogram. And if you review the heart failure therapy and switch to non-teratogenic heart failure medications. Then you classify them based on your assessment as low risk, moderate, and high risk. For the low risk, you would discuss with a specialist center for high risk pregnancies, and then reassessment at the beginning of the second trimester, that is at 20 weeks. And then for the moderate and high risk heart failure patients, that's the modified WHO class 1, 2 to 3, and 4. They would have a referral to a specialist center for high-risk pregnancies with multidisciplinary pregnancy heart team. So they're required to have a heart team, pregnancy heart team, where they go for their ANC. And then you reassess them at the beginning of the second trimester, that's at 20 weeks. And then you also reassess at 20 weeks. And then bi-monthly or monthly review if they are WHO class 2, monthly review if they are WHO class 3, and urgent counseling for consideration of pregnancy termination for those who are WHO class 4. So that was just the algorithm for pregnancy. The rest has to do with some cardiomyopathy, genetic cardiomyopathies. So I'll go on to the updates. So in 2023, which was now 2 years ago, the ESC guidelines was reviewed. And the main areas that they looked at, recommendations following this, reviewing the various sections of the 2021 guidelines, the main areas that they reviewed was the management of chronic heart failure, particularly for mildly reduced ejection fraction and preserved ejection fraction. And then also for management of acute heart failure, as well as comorbidities and the prevention of heart failure. So for the management of heart failure with reduced ejection fraction, these are the recommendations that were made. Class 1 recommendation for diuretic therapy for fluid retention. SGLT2 became a class 1 indication, and then ACE, ANI, ARB class 2B, MRA class 2B, and beta blocker class 2B. So initially, the SGLT2 was also a class 2B, and now it became a class 1 indication. This was based on some studies that were conducted between the period of the 2021 and 2023. So at the time of 2021 guidelines, there was not much evidence for the role of SGLT2 inhibitors in heart failure with mildly reduced ejection fraction. But then the Emperor Preserved trial was conducted, and there was some evidence for benefit in its use in heart failure with mildly reduced and preserved ejection fraction, because it recruited patients who had LVEF more than 40% at the time of recruitment. And then, so that is what informed the inclusion of SGLT2 inhibitors as a class 1 recommendation for the management of heart failure with mildly reduced ejection fraction. So SGLT2 inhibitors, which is dapagliflozin and empagliflozin, is recommended for patients with heart failure with mildly reduced ejection fraction to reduce the risk of hospitalization or CV death. So that's class 1 level of evidence is A. And for heart failure with preserved ejection fraction, class 1 indication for diuretics, class 1 indication for empagliflozin, and class 1 indication for the etiology CV and non-CV comorbidities. So here too, we find that SGLT2 inhibitors have been added to the class 1 recommendations for management of heart failure preserved ejection fraction. I think that was based on also on the Emperor preserved, and there were 2 studies, the Deliver trial and the Emperor preserved. That's what informed these updates. Okay. So for acute heart failure, the recommendation, the update is that the recommendation for pre-discharge and early post-discharge follow-up of patients hospitalized with acute heart failure. So an intensive strategy for initiation and rapid up titration of evidence-based treatment before discharge and during frequent and careful follow-up visits in the first 6 weeks following heart failure hospitalization is recommended to reduce the risk of heart failure, rehospitalization, and death. So that's a class 1 recommendation with the level B evidence. Was based on the strong HF trial. So initially, we used to do a stepwise introduction of the disease-modifying heart failure medications. However, this new recommendation is to initiate them all together if possible, or do a rapid up titration of these evidence-based treatments whilst on admission before discharge, and continue to do so during their follow-up in the first 6 weeks of their following their discharge. And for the next one was the prevention of heart failure in patients. So for the comorbidities, the update was on recommendations for the prevention of heart failure in patients with type 2 diabetes or chronic kidney disease. Also here, patients with diabetes and CKD, SGLT2 inhibitors are recommended to reduce the risk of heart failure, hospitalization, and cardiovascular death. That's class 1, level A. And also in patients with type 2 diabetes, mellitus, and CKD, finerenone is recommended to reduce the risk of heart failure, rehospitalization. So these were based, I think, the coach trial for the finerenone. Let me confirm that. So I'll confirm the trial, I mean, when we are asking the questions, but that's what informed the use. Class 1A recommendation for finerenone, and then also SGLT2 in patients with type 2 diabetes and CKD. And then for patients with anemia, we have a class 1 recommendation for IV supplementation in symptomatic patients with HFrEF and HF mildly reduced ejection fraction with iron deficiency to alleviate heart failure symptoms and improve quality of life. So remember that for the mildly reduced ejection fraction in 2021, it is if they had had a recent admission. But now for both of them, HFrEF and HF mildly reduced ejection fraction, so far as they have evidence of iron deficiency and are symptomatic for the heart failure, you'd want to replace or supplement their iron with the ferric carboxymaltose. And then intravenous iron supplementation with ferric carboxymaltose or ferric derisommaltose should be considered in symptomatic patients with HFrEF and HF mildly reduced EF and iron deficiency to reduce the risk of hospitalization. That's class 2A. So they have now added on ferric derisommaltose. Initially, it was just ferric carboxymaltose that they had in the recommendations, but derisommaltose has been included now. So that brings me to the end of my presentation. Thank you
very much. Thank you very much. I think let's show appreciate the presenter in the chat box. I think she's done extremely well. She's been talking 2 hours straight. 2 hours straight. And we are happy to have this as the first presentation to set the tone and the kind of material we are hoping to have during these periods of presentation. Thank you very much, Florence. Not to waste too much time, the floor is open for questions, contributions, clarifications. Thank you. If we have, whilst we are waiting, if we have any consultants, I don't know whether Prof is on, let me check, or Dr. Kopi, Dr. Allison, Dr. Conte, any senior person on who wants to make some initial comments whilst we await questions, contributions, and clarifications. I see Dr. Kweki on.
Hello, Dr. Eugene.
Yeah, hello.
Yeah, sorry, let me just make my comment because sometimes I don't have power over my time because of a lot of other activities. Apologies that I didn't start from beginning. Can you guys reduce the volume, please? I didn't start from beginning because of some other commitments. I catch up with discussion along the way, so that's a brilliant discussion. I saw when you were talking about the ASC guideline vis-a-vis indications for use of diuretics and some vasodilators. I also meant when you talk about the algorithm for heart failure and pregnancy, as well as heart failure and cancer patients. So for me, I wasn't here from beginning, but for you to have kept on for 2 hours, you did a brilliant job, to be fair. I don't have more to say, but just to also bring it to our attention that whenever you see a patient in heart failure, either presenting with acute heart failure or patient already know to have stable heart failure, not presenting with decompensation, it is so important to know the cause of the acute heart failure de novo. Okay, but for the patient that presents with decompensation, you would have known the possible etiology. At that time, you're really concerned about the cause of the decompensation. And I like the fact that you said for patients that have rapid AF with rapid ventricular response, if they are not responding to medical treatment and if there are no contraindication, sometimes cardioversion, DC cardioversion will be a way to go. So this is important because again, there are some patients that may need to be cardioverted and that can improve the symptoms. Okay, so just to put a final touch is that whenever a patient comes with acute heart failure, the etiology is important, and that tends to tell you the direction to go. That's why most time patients with acute heart failure, we tend to look at it from the perspective of whether ischemic induced or non-ischemic induced. So that's one of the classification because that tends to help us in the approach of treatment. And sometimes you may want to see whether you can revascularize the patient, because if you can do that in the acute episode, you could improve their symptoms. And sometimes once they are not in acute episode and they have symptoms of heart failure, you've done your echo, you're seeing regional wall motion abnormality, you're seeing dilated the left ventricular, the left ventricle is dilated with impaired systolic function. Sometimes you want to go further and look at this patient further. Vis-a-vis, you want to do things like cardiac MRI. That's where your PET scans are coming in. That's where your SPECT are coming in. Because you want to see whether this patient is a candidate that you want to revascularize or is a candidate that has extensive fibrosis where you don't want to go further. So it's important for you to look at the etiology. And I can tell you that in our current world, we're beginning to have the immunotherapies. And we need to look at those perspectives. I've had this situation where I've seen patients that were started on immunotherapies and they started coming down with features of heart failure. So we need to look at that, not just the usual cancer medication that we know, but we need to start looking towards immunotherapy because these are now widely used in treatment of so many medications, in so many conditions, including the use of biologics. So the point here is that whenever you see a patient, it is important for you to know the etiology. I also understand that in our settings, especially in the sub-Sahara area, hypertension appears to be the most commonest cause of heart failure. But sometimes these are also investigation-based. We need to also open our mind to start drifting into those directions, whether beyond hypertension, if the patient is having some underlying ischemic heart disease. Because a patient presenting with heart failure with any regional wall motion abnormality, if the heart failure is stable and chronic, it is reasonable for you to go further to do things like cardiac MRI to be able to assess further and see if the patient will benefit from any form of intervention. I don't have questions to ask, really. Just wanted to add this comment. For me, it's a brilliant presentation. Thank you so much. I think it's Florence, right? If I'm correct. Thank you. And let's keep up the spirit of presentation. Thank you so much. Thank you.
Thank you, Dr. Kweki. Any questions, contributions from colleagues?
Yeah. Hello, Eugene.
Yeah, Dr. Conte.
Yeah. Can I make some few comments?
Please go ahead.
Yes, fabulous presentation by Florence for covering this very, very, very cardinal topic in heart failure. I normally say heart failure is the bread and butter for cardiology. All the other conditions that you'll be talking about subsequently, they all come through this final common pathway of heart failure. From your arrhythmias, valvular heart problem, congenital heart, infiltrative heart disease, they will end up causing is heart failure. So it's appropriate that we started with it, and it was very beautifully delivered. Because of the importance of this topic, especially since we are preparing for exams, so heart failure questions features a lot. Okay, so important things that you must pay attention to and try to, find somewhere to keep them in your mind. The definitions for advanced failure, they are very common features in MCQs, both past questions and even when you go through your brown work, indication and contraindications for transplant. Okay. And also in the MCQs, they like the clinical scenarios of managing a patient with chronic heart failure with some of the guideline medications and how you sequentially go for the class 2B indication, where in a scenario, they will give you the patient is on all medication and maybe give you one parameter that is off and then ask you what is the next step. So what are the things that you look for to consider adding ivabradine, for instance? What are the things you look for to consider a patient for CRT, for ICD? So those should be clear in your mind because those are the areas that they ask, especially in the clinical questions in the MCQ. The management of acute heart failure and advanced heart failure, it's very important. In fact, there is a past question on the management of a patient who is on all 4 medications, but is still having symptoms, and the patient comes to you. How do you proceed? Okay, so that one has featured before. So probably the next time what would come around is how you manage patient with acute decompensated heart failure. So those are the things you need to know to your fingertips. In terms of the management of heart failure with preserved ejection fraction. So we must be aware that after the 2023 guideline, 2023 update, there's also another study that has come out to show benefits, benefit of finerenone in the management of heart failure with preserved ejection fraction, the FINE heart study, and as a result of that study, in fact, some experts are suggesting that, the data for the TopCat study, which used spironolactone, should be reviewed, and if it is properly analyzed, there might be some benefit for actually spironolactone. So subsequently, we should be looking at further updates to include finerenone also in the guideline for management of heart failure with preserved ejection fraction. Another thing also that we must pay attention to are the trials. Like I said, heart failure is the bread and butter. So the trials for the key medications that you use, you must know them. And when answering questions, especially in the Viva, you must be able to mention, when you mention a particular treatment, you must be able to mention the landmark studies that, support those treatments. It is also very important. You also mentioned, stress the strong HF trial that, emphasize the simultaneous starting of all the main medications you use for heart failure. So that is the teaching. But in clinical practice, you know that it is not always possible for you to start them together. So you will still find yourself in a position wherein you have to sequentially introduce the medication, okay? So with that, I want to ask a question to you, Florence. So if you have a patient who has come with acute decompensated heart failure, the blood pressure is hovering around 95-60, okay? And you've started diuretics. So of those 4 medications, how would you sequentially, introduce those medication to prevent the patient from going into hypotension and deteriorating further? Thank you.
Thank you, Dr. Conte. Any contributions? Any contributions? Okay, so I think Florence. Florence. Hello? Hello?
Yeah, hi.
Any last
Sorry.
words? Any last words?
Well, like as the presentation went, it was quite broad, and there are various situations where we have to make different considerations, especially with
Dr. Florence, did you hear the question that was asked? Dr. Conte asked a question.
Oh no, I didn't. Sorry, could you repeat it?
Okay, he said if you have a patient that comes in with heart failure, acute heart failure, and then you want to introduce the Fantastic Four for heart failure, how are you going to introduce it to prevent hypotension?
Okay.
Thank you.
So in the context of what's it called? In the context of the ESC 2021, that was when they were to do the stratified introduction. I believe that in the update, that was no longer a caveat where you are going to start one and monitor the response and add on the other. So I'll have to look into that and get back to you. But I think it was the 2021, but in 2023, in the updates that I read for the acute heart failure, yes, acute heart failure in pre-discharge recommendations, you are to start all within a space of 6 months of 6 weeks of their admission. You initiate all if there are no contraindications to their introduction, and up titrate within 6 weeks of their admission.
Okay, Florence, I think what Dr. Conte wants to draw attention to the practicability of it and the risks, since most patients who come with heart failure are likely going to have relatively low blood pressure. So I don't know whether the answer Dr. Conte is expecting now. I'll give a try. Is to, if you're starting these medications, the 4 of them, you start them at the low doses. across board. You don't start all at high doses. And there are some medications that are at relatively higher risk of causing hypotension than others. So if you're having a patient who relatively has blood pressures that are low with evidence of hypotension, because the reason why it's important to look at significantly low blood pressures with signs of hypertension is that generally patients with heart failure are likely going to have lower blood pressures, but that should not deter us from initiating these medications. So the MRAs affect blood pressures more than, let's say, beta blockers, and ACE inhibitors or ARBs also affect blood pressures relatively higher than beta blockers. So you should be cautious with these two medications when you are concerned with blood pressure, whereas SGLT2 and beta blockers have relatively low effect on the drop in blood pressure. I don't know whether that's what Dr. Conte is expecting for us to say. If he's still on, if he can.
Yeah, you're absolutely right, Eugene. But you must remember that among the 4 medications, okay, the SGLT2 inhibitors are what are considered to be relatively blood pressure neutral. So in a case wherein you are worried about hypotension, they are relatively safer compared to the other medication to start with. And then as you're able to maintain the blood pressure, then you can sequentially bring in, if they are decongested, then you can consider coming with the beta blocker. But if they are still congested, you have to defer the beta blocker. And the next thing you want to consider are your ACE inhibitors. So the MRAs would be, if you are looking at because of fear of hypotension, the MRA will be the last for you to introduce when you are worried about a patient going into hypotension. Another thing that we should take note of is that, of all the heart failure medications, only the SGLT2 are prescribed in a fixed dose. Okay, whether you are starting, you are continuing, SGLT2 are 10 milligrams. Okay, you don't go above that and you don't have to titrate. Whereas, as Florence showed the tables, it is important to remember the maximum doses also of those medications. And even for practical purposes, you make sure that you do not develop clinical inertia, because the more once you titrate and get up to their maximum tolerated dose, the patients benefit more from the medications. Okay. All right. Thank you.
Let me see.
Okay, and thank you very much, Dr. Conte. So I think I've taken quite your weekend, 2 hours, 20 minutes. So in the absence of any further questions, I want to say thank you to everyone. God willing, tomorrow we'll continue same time with Dr. Catherine on supraventricular tachycardias. Have a wonderful evening. Thank you all.